Let's talk about induction of labor. 20% of pregnant women undergo induction. Cervical ripening. Bishop score less than 6 is considered unfavorable. We should allow at least 18 hours of labor before diagnosing failed induction. Greater than 8 Bishop score has a probability of vaginal delivery as same as someone who comes in spontaneous labor. Methods of labor induction: vaginal prostaglandins when compared with placebo or oxytocin alone has increased likelihood of delivery within 24 hours. Do not reduce rate of C-section, increased risk of tachysystole. In these cases, we can use terbutaline. Irrigation of cervix or the vagina is not useful when there's tachysystole. Vaginal misoprostol compared to PGE2 and oxytocin has higher rate of tachysystole. Decreased use in epidural, more vaginal delivery within 24 hours. Misoprostol 20 mics Q4. Oxytocin cannot be started less than 4 hours from the last misoprostol dose. PGE2 vaginal insert 0.3 milligrams per hour sustained release. You can do that for 12 hours. 30 minutes before oxytocin can be started after removal. PGE2 relative contraindications: glaucoma, severe hepatic or renal dysfunction, it is a bronchodilator. Uterine contractions usually are evident within the hour, with peak activity in 4 hours. Prom patients, vaginal PGE2 for induction of labor in patient with prom appears to be safe and effective. Only one dose of intravaginal misoprostol was necessary for successful labor induction in 80% of patients that came in with prom. No evidence of PGE induction in prom patients increase infection risk. There is no data on mechanical dilation in prom patients. Induction with either PGE or oxytocin reduced the risk of chorial and endometritis, reduce NICU admission. Oxytocin, uterine response ensues after 3 to 5 minutes. Steady level in plasma is achieved by 40 minutes. Gradual uterine response to oxytocin from 20 to 30 weeks, followed by a plateau from 34 weeks till term when sensitivity increases. Addition of oxytocin along with the use of Foley catheter does not appear to shorten time of delivery. Side effects: uterine tachysystole, water toxicity if using hypotonic solution. High dose regimen is associated with shorter labor costs, less frequent cases of chorial and cesarean delivery for dystocia. increased this is labor dystocia, increased risk of tachysystole with associated fetal heart rate changes. Usually it's starting at 6 and increase increments of 3 milliunits per minute every 15 to 40 minutes. So for oxytocin, it's usually, this should be up here, 10 units in a 1 liter normal saline, or 10 units per milliliter. Membrane sweeping increased in phospholipase A2 and prostaglandin F2 alpha. Increased spontaneous labor within 48 hours. No data if the GBS positive, so no recommendation on that. Amniotomy, insufficient evidence on the efficacy and safety of amniotomy alone. For induction, shorter induction to delivery interval when amniotomy and oxytocin together. No recommendation on timing when GBS positive. Contraindicated in HIV positive women. Length of rupture is an independent risk factor for vertical transmission. Nipple stimulation decrease in postpartum hemorrhages. Unfavorable cervixes decrease in number of women not in labor at 72 hours was noted with nipple stimulation versus placebo. However, there is an increased perinatal death. Nipple stimulation is not recommended in unmonitored settings. Uterine contraction. So number of contraction over 10 minutes, averaged over 30-minute window. Tachysystole is greater than 5 in 10 minutes over 30-minute window. Should be qualified as to the presence or absence of fetal heart rate deceleration. Indications and contraindications to induction. Indications: placental abruption, chorial fetal demise, hypertension, PROM, post-term pregnancy, maternal medical conditions, or fetal compromises. Contraindications: vasa previa, transverse fetal lie, cord prolapse, classical C-section, active genital herpes, prior myomectomy into the endometrial cavity. Criteria for induction: allow at least 18 hours of labor before diagnosing failed induction. We need to confirm term pregnancy. Ultrasound less than to confirm term pregnancy, we can use ultrasound dated less than 20 weeks supporting gestational age of 39 weeks. Fetal heart rate documented as present for 30 weeks by Doppler. Has been 36 weeks since the positive pregnancy test. Fetal demise in the late second or third trimester, less than 28 weeks. Vaginal misoprostol is the most efficient, 200 to 400 mics every 4 hours. Prior uterine scar, 400 mics Q6 has not been shown to increase complications. So arrived child, the arrived trial, 6,000 nulliparous low-risk women randomized to induction of labor at 39 weeks versus expectant management. No difference in primary perinatal outcome. However, there is a decreased C-section rate, 19 versus 22%. There is a decrease in hypertensive diseases, 9 versus 14%.